Natalie or Terry, can I just check my microphone is working with you?
Yes, I can hear you, Kate.
Yeah.
Lovely, thanks.
It's all very quiet, isn't it, when everyone first joins?
Fine. I'll not put my camera on because I'm not on for a bit. I just wanted to check my microphone was working. Thank you.
Yeah, you are. Thanks so much. Ken, it's over to you when you want to start. I don't know
Great,
if you want to give it
you
a
ready
couple
to
of minutes,
start?
but yeah, up you go.
Okay.
I can stop sharing.
Am I center screen now? Hello? Yeah,
Yes,
good. Okay.
yes, you're there.
Great, okay. Welcome everybody. My name is Ken Hodson. I'm a consultant obstetrician in Newcastle and part of the North Cumbria network, and it gives me great pleasure to chair this webinar this afternoon. It's a joint meeting between two networks, so Yorkshire and Humber and North Cumbria, and it's the second such webinar that we've done in recent years. Today there's a wide range of topics. We're going to be talking a bit about maternal medicine networks, a bit about congenital heart disease, hypertension in pregnancy, and then transplant. And it's great that it's a multidisciplinary meeting. So there's a wide range of healthcare professionals involved in this meeting, and you're all very welcome. We would really encourage you to ask questions in the chat. So I'll be chairing the meeting and keeping a half an eye on the chat function in Teams. So if you do have a question, I think your microphones are muted, but please do put questions in the chat, and there will be time for some question and answer sessions with the speakers as we go through the programme. So I think the first person to start the meeting is Natalie Anderson. Natalie, hope you're ready. Natalie is a specialist maternal medicine midwife in Yorkshire and Humber, and is going to talk to us this afternoon about maternal medicine networks and cardiology referral pathways.
Thank you. I'll just share my screen. Can you all see that? Just give us a thumbs up if you can see.
We can do, yeah. Thanks, Natalie.
Yeah. Okay. So as Dr. Hodson said, so my name is Natalie and I'm the maternal medicine specialist midwife, and I'm based at the Leeds MMC, which is part of the Yorkshire and Humber maternal medicine network. So I think I was just asked to talk to you today just about the networks and how they work, and kind of the referral processes. So maternal medicine networks were set up to improve the equity of access to specialist services for women with complex medical conditions before, during and after pregnancy. So the idea of the network is wherever you live. So for example, if you live in Scarborough, you should have access to the same specialist services and kind of medical care within pregnancy and afterwards as you do if you live within Leeds. So the idea was to reduce maternal mortality, improve health inequalities, and again, just to try and the idea is that they have as much care locally as possible. So the women would be seen and usually booked by their local community midwives, would have obstetric oversight locally, and then we would expect a referral to the maternal medicine centres. Some ladies we do want to see a bit earlier, but I'll come on to that later. So I'm conscious that this is run by two cardiology networks. So I obviously work at the Yorkshire and the Humber Maternal Medicine Network, and we have two maternal medicine centres. So we've got one at Leeds and one in Sheffield. How it works in Yorkshire is that we tend to take the Humber as the dividing line. So anybody booked at a trust north of the Humber would tend to be referred to Leeds, and anybody south of the Humber would tend to be referred to Sheffield. There is some caveats to that though, in that the kind of the referral pathways don't quite map onto the cardiology pathways. So for example, patients from Grimsby, sometimes we'll see them in Leeds, and we'll see them in Leeds if they've had if they've already been having their care within Leeds. And the same for Sheffield. So if they're known to Sheffield, they'll carry on going there rather than coming to Leeds. The North East and North Cumbria Maternal Medicine Network, I understand that you have one MMC, which is in Newcastle. So I just wanted to show you this. I've stolen it from a colleague. I just thought it was quite interesting. So this light blue area here is Yorkshire and Humber, and this is, it says Cumbria in the northeast, but the northeast and Cumbria. And you can see kind of geographically, we probably cover maybe a fifth, a quarter of the country. And then if you just compare that down here, which is London, within this area here, there are 5 different maternal medicine centres. So they have with 7 maternal medicine centres, sorry, 5 maternal medicine network with 7 maternal medicine centres. So compared to the 3 in Yorkshire and the North East. So obviously we do have different challenges compared to London in terms of the big geographical area we cover and the challenges for the, excuse me, for the women to actually get to the centres. So maternal medicine networks, how it works is that for each condition, they're categorised into a category A, B or C condition. So women with a category A condition, which for example, essential hypertension, epilepsy, they can be managed locally. And us as a centre, we wouldn't kind of need to know about them. Women with category B conditions, we would expect a referral. Often they'll just come for 1 or 2 appointments and then we can refer them back to their local hospital for delivery. We do tend to see a lot of these ladies within the cardiology clinic, and it's kind of, we just provide reassurance of their local trust that actually from a cardiac point of view they're okay. Women with a category C condition, the condition we recommend is led by the maternal medicine centre. It doesn't necessarily mean some women are advised to have all their care within the centre, but most women, especially from cardiology, they would carry on having antenatal care locally. And some women, most of these women we would recommend delivery within the centre. Again, that's not a hard and fast rule. Some women can deliver locally. So I'm sure Dr Hudson will correct me if I've got any of this wrong, but I understand from Claire that for the North East and Cumbria that they have a joint obstetric cardiology clinic on the 1st and 3rd Thursday of the month, and that is based at the Freeman Hospital. They have 2 obstetricians and 2 cardiologists that do alternate clinics, and Claire Bogue is their maternal medicine midwife, who they have a midwife in that clinic as well. I also understand from Claire that very sensibly everybody in the North East is on Badger Notes for their maternity system, and that's how they get their referrals. So the referrals come through Badger Notes and then they will be triaged by a midwife, and they can and then I also understand that you can see each other's notes via that referral thing, which sounds absolutely amazing because that isn't how it works in Yorkshire, but I'll come on to that. I also understand that you use the National Service Specification as your criteria for referral. So these are A's, B's, and these are the C's. So any of these in these categories will be referred accordingly, and this can be managed locally. So just going on to the referral pathways for Yorkshire, we have to do it via an email system and a referral form. There are at least three different systems within the regions. We have K2 Cerner and Badger Notes. I think it's only Badger Notes that has interoperability, and unfortunately neither MMC uses Badger Notes. So Leeds is on K2 and Sheffield are about to be or going to be or currently on Cerner. So it means that we cannot see the antenatal notes from the DGHs. So we do spend a lot of time, me and my colleague Vicky in Sheffield spend a lot of time kind of making sure clinic notes are transferred and liaising with the DGHs. We also do, and I believe this is the same in the North East, we run MDTs with their local trust as well once a month. So that we can liaise and make sure they have all the information that they need. But it's a lot of a lot of work that goes into that. So Leeds, we have a joint cardiology obstetric clinic every Monday afternoon at the LGI, and we have 2 clinics that run side by side. So there's we have 2 congenital cardiologists and 2 acquired cardiologists, and as I say, they run the clinic side by side with obstetricians. We also have an anaesthetist present, and myself, I cover both of the clinics. In Sheffield, they have a joint clinic every other Monday afternoon, again with 2 cardiologists, obstetricians, and an anaesthetist present. And as I say, Vicky Elliott is my colleague in Sheffield. So we've adapted the criteria for referral, and we've changed it slightly. So I've noticed that it's actually the other way around from the service specification. So these are your category A conditions, these are B's, and these are C's, and then we've added sort of an urgent referral. So these are the women that we would want to see as soon as they found out that they were pregnant. Often the women do let us know before they've even booked with their midwife. And these are the ones for the congenital as well. So we've split it for acquired and congenital. So that especially mechanical heart valves, we'd want to know straight away. So I just wanted to just have a talk about the role of the midwife within the clinic. So we do add that extra midwifery care. We don't caseload the women. But especially if women say are an inpatient for a long time and they've missed a community midwife appointment, we'll try and make sure that I will go and see them and make sure that we've covered everything. We look at everything, so the mental health, the safeguarding, the public health messages. If there is a woman that is, this isn't the same in all the centres, but from my point of view, if there is a woman that has been recommended to deliver in Leeds for a medical reason, then I would book her for delivery in Leeds if she's having shared care, and I would sort out all the clinic appointments and make sure that we had all the information that we needed for safe delivery within Leeds. Communication, I've put that in like really big bold letters because that is a really big part of my role. In my experience, just personally, I've found that the one thing that kind of women, or the one thing that causes the most anxiety, is if when they go to their local unit and they say, oh, we don't know what's happening in Leeds, and vice versa. So I really try and make sure that communication is good for the women. So those are my email addresses for Yorkshire, and apologies I didn't have one for the North East. I didn't want to put a wrong one on, so that's all I had to say really. So thank you very much for listening. Stop sharing.
Great, thank you very much, Natalie. Yeah, I mean, the maternal medicine midwives do play such a fundamental role in part of the network, and certainly I think in the North East we've seen, just as the network has kind of evolved and developed, the kind of workload has kind of mushroomed really, and what was set up as a sort of kind of low-key, I suggest, amount of obstetricians and midwives and other physicians is now needing to sort of expand rapidly, I would say, in the next 5 to 10 years. Do you find that is true in the Yorkshire and Humber region as well?
Yeah, definitely. Yeah, the workload seems to have really ramped up. Yeah, I mean, as I say, it doesn't help that we don't have access to the other systems. I mean, that how you do it sounds amazing. But yeah, it has really ramped up, and at the moment there's just me in Leeds doing it. So
yeah, I think that I mean, Badgernet does help, I think, but I guess there still is this kind of issue that medicine and cardiology notes are held in a sort of the hospital system, which is e-records, and Badgernet is still maternity, although all of our maternity units use Badgernet. Okay. So you still find yourself having to sort of cut and paste off Cerner into Badgernet if there's sort of clinical reviews that haven't been put onto Badgernet. So it is a bit better for communication between units. Yeah, but very good. I don't know if anyone else has any questions in the audience. I can't see any in the chat at the moment. I wonder if our next presenters are perhaps ready to continue.
Yep.
Eleanor,
Yep.
is it, and James is also coming to the meeting, or?
No, I'm doing the presentation today. Yeah.
Right, okay. Thank you very much. So it's a pleasure to welcome Eleanor Joy, who's a consultant in adult congenital heart disease in Leeds, and she's going to be talking about congenital heart disease in pregnancy. Thank you.
Yeah, thank you. So, as Ken said, my name's Ellie Joy. I'm a consultant in adult congenital heart disease in Leeds General Infirmary. And as Natalie mentioned, I do the cardio-obstetric clinics on alternate Mondays, along with my colleague, Dr. James Oliver. So thank you for inviting me to talk for sort of the next 45 minutes about patients who are pregnant with congenital heart disease. We will start with discussing the sort of physiological changes in pregnancy that affect the heart, look at the risks for women with congenital heart disease and who is the most at risk, and then sort of with regards to symptoms that they may present with, what the red flags may be, and use some cases from patients we've had in the last couple of years to highlight how these patients might present acutely. In terms of why this is important, so congenital heart disease is the most common congenital anomaly, and it occurs in around 1% of all live births. And over the last few decades, there's been so many improvements in both sort of medications, but also surgical and percutaneous techniques, that patients who are born with congenital heart disease have a much better survival than they did if they were born a few decades before. And the graph on the right sort of demonstrates that back in the late 80s, unfortunately, over 25% of children born with congenital heart disease would die before they were 1 year old. But coming into sort of 2004, 2005, it's much more aligned with the general life expectancy, which is the black line. And as a result, with increasing survival, you're going to have more women reaching childbearing age and therefore contemplating and then pursuing pregnancies. Now, whilst many of our patients are able to tolerate pregnancies very well, there will be certain conditions that will have much higher risk pregnancies, and there will be issues with regards to both maternal and fetal morbidity and mortality. And as a result, MDT involvement is crucial in ensuring the best outcomes for these patients. And that's, the setup that we have both here and in Newcastle, with both cardiology, obstetric, anaesthetic, and obviously midwifery input as well. Now, when you should look at sort of normal physiological changes in pregnancy, a lot of these changes occur very early on. So, by the end of the first trimester, there's been a significant increase in the cardiac output, increase in sort of the circulatory volume, an increase in heart rate, and then by the middle of the second trimester, this then plateaus and just has to be sustained until delivery, where there is quite a rapid normalization back to baseline. There are also potential changes that can be noted on ECGs and echocardiograms, and it's quite useful to know what is allowed and what we would be concerned about. When patients who are pregnant have an ECG, it can be common to see some changes in their T waves. So they could become flattened or they could become inverted, illustrated by the purple line on the ECG change. And the PR interval can also become slightly shortened as well. When we look at their ultrasound scans in pregnancy, there can also be changes with regards to the size of the chambers themselves. So both the atria and the ventricles, it can sometimes dilate a small amount in pregnancy, and occasionally a small amount of fluid can collect in the sac that the heart sits in, which is called, a pericardial effusion. However, there are some changes that we would not expect to see in pregnancy, such as an increase in the size of the aorta, a reduction in the ejection fraction, so a reduction in the strength at which the heart can contract, or a rise in the pressure within the lungs. And these sort of normal physiological changes that happen in every pregnancy can have a greater impact on some of our patients with congenital heart disease. So, for example, that normal volume loading that everybody will experience will increase the risk of heart failure in our patients that already are predisposed to that. And again, arrhythmias as well can be more persistent in pregnancy, especially in those patients who are known to have a predisposition because of their congenital heart disease. For our more complex patients with cyanotic lesions, so these are patients who have a mixing of the oxygenated and deoxygenated blood within the heart, meaning that their saturations are much lower. These patients are known to have much higher risks of miscarriage and also known to have growth restriction of the fetus as well. And the other sort of group of congenital heart patients that do struggle in pregnancy and those with a fixed outflow obstruction, so any condition where there is a narrowing preventing the blood from leaving the heart as well as it normally should. Again, they don't tolerate the increase in volume and physiological changes in pregnancy as well as others do. But it's not just the impact on the heart. We know that patients with congenital heart disease are also known to have higher risk from obstetric complications such as hypertension and preeclampsia and postpartum hemorrhage. For those most at risk of high blood pressure, this is those patients with a coarctation of the aorta. This is a condition where the main blood vessel that leaves the heart, called the aorta, is narrowed. That's present from birth and normally is identified as a child or as a neonate and corrected with surgery, but there are some cases where this isn't picked up until later in life. And even those who have had this abnormality repaired in childhood do still have a higher risk of developing high blood pressure later in life generally, but especially during pregnancy. With regards to hemorrhagic risk, we find that those with a lower oxygen saturations are at a higher risk of hemorrhagic complications. So those include Eisenmenger's, which is where there is a hole in the heart, but the blood is flowing. Sorry, excuse me. The blood is flowing from the right side to the left side of the heart. And because they have low oxygen levels, this then actually affects both the number of platelets, but also the function of platelets, which then has an impact on sort of bleeding complications as well. But even those with what we would deem to be relatively mild issues, such as a repaired hole in the heart and therefore pretty much a structurally normal heart, do still have higher risks of obstetric complications when you compare this to patients who are born with structurally normal hearts. We also need to consider the potential risks from a fetal perspective as well. Sadly, there is a much higher risk of miscarriage in these patients with congenital heart disease, as well as premature delivery and babies being small for gestational age. We also need to consider the fact that patients with congenital heart disease will have a higher risk of having children with congenital heart disease. And whilst for the majority of the conditions we estimate this at sort of 5 to 8% based on the current literature, there are conditions that have a higher risk, such as bicuspid aortic valve, which is illustrated below, where the valve that separates the main pumping chamber and the blood vessel taking blood away from the body forms with only 2 leaflets instead of the usual 3, therefore opening like an oval as opposed to a triangle. And if you yourself have a bicuspid aortic valve, there is a 10% chance that your children will have similar. And then conditions such as Marfan syndrome, which are autosomal dominant, will therefore have a 50-50 chance as to whether their children will have the same condition. Although I've not broached on it in this presentation, we are now starting to liaise with both our reproductive medicine colleagues and also genetic colleagues to consider pre-implantation genetic testing for those patients with conditions that have a 50% chance of passing on to their children. So who is actually at risk? So the World Health Organization have a agreed criteria, and a couple of months ago, the European Society of Cardiology issued new guidelines regarding cardiovascular disease in pregnancy, and they've upgraded this to now the 2.0 classification. Similar to the old table, if you've seen that in the past, it still has 5 different categories ranging from class 1 to class 4. Class 1 is the lowest risk, going up to class 4, which includes patients where actually pregnancy would not be advisable due to the significant maternal risk. When you look at what conditions are included in each category, those in the lowest category are patients who were born with a simple defect, such as a hole in the heart, which has been repaired either with an operation or with a device inserted through the groin. And as a result, these patients now have a structurally normal heart. They do remain under follow-up, but from a pregnancy perspective, there is actually no detectable increased risk compared to the general population, and we would be happy for these patients to be managed by their local teams without any adjustments to their sort of antenatal delivery plan from a cardiac perspective. As you then move up the classification criteria, you'll become more and more complicated in terms of the types of conditions we have, until you get to obviously group 4, where we do have quite difficult and complex conversations with these patients prior to pregnancy regarding their risk, and also often repeat these conversations during their first appointment with us to ensure that they do fully understand the risks that they are undertaking if they want to continue with the pregnancy. And these are patients who have significant heart failure. So obviously the heart isn't pumping as well as it should. They're patients with a Fontan circulation. So this is patients who end up having just a single pumping chamber in the heart instead of the usual 2. And Eisenmenger's, which I mentioned previously, where the blood is shunting from right to left, therefore having very low oxygen levels. And these women do have a risk of up to 50% of maternal mortality or severe morbidity. As to be expected, the antenatal care will depend on the level of risk. And as I mentioned, those with very mild disease don't need to have the involvement of the sort of regional cardio-obstetric clinic, can be managed locally. Whereas those with more complex disease, we do like to see. Often those with sort of moderate disease, so things like tetralogy of Fallot or transition of the great arteries, but with good surgical outcomes, often have shared care and sort of local delivery, but we see them a few times during pregnancy. And those at high risk, so the group 3 and group 4, we will deliver in our centre in Leeds, and those at the greatest risk are coming to clinic almost every other week at times, especially at the later stages of pregnancy. We also have a guideline for our specialist nurses that they have in their office for when patients do call them. As Natalie mentioned, we often find out before the GP or the midwives do locally that they're pregnant, and our specialist nurses therefore run through a screening checklist to review how soon these patients need to be seen in clinic. One of the important questions, obviously, do they wish to continue with the pregnancy? Even patients who do not wish to continue, if they are high risk and have complex congenital heart disease, we do still then liaise with our obstetric colleagues with regards to advice on potential risks with termination. The nurses also then review whether there are any medications that need to be stopped urgently that aren't suitable in pregnancy, in particular ACE inhibitors, so ramipril and allopril, the NOACs, so the newer agents for blood thinners, such as apixaban, edoxaban, dabigatran, and also warfarin. They also advise patients to ensure that they're starting folic acid and vitamin D supplements, give general lifestyle advice about smoking and alcohol, and then ensure that follow-up is arranged in the obstetric clinic. Similar to the modified WHO criteria, we simplified it to low, medium and high risk. Those at high risk we see at the next available clinic. Medium risk, we wait until there's confirmation that the pregnancy is viable and see them shortly after their first scan. And low risk patients, as we cover such a large geographical area as Natalie highlighted, we tend to combine this with their fetal echo between 18 and 22 weeks gestation. So they only have to come through to Leeds once. Moving on to sort of symptoms and red flags to look out for. The reason sort of highlighted this as all staff is, looking through when we got sent the delegate list, there's quite a variety of specialties joining, people from obviously from the ambulance service, midwives, obstetrics, cardiologists, and it's just important that anyone who has a clinical contact with a lady who's pregnant needs to be aware of the potential things to look out for and then know how to escalate if needed. And as you can see, for sort of 4 of those boxes, these are symptoms that can be sort of severe in terms of, they happen in pregnancy, but they're not related to any significant pathology. It's very common, especially in early pregnancy, that someone may have a simple vasovagal faint without it being related to any concerning arrhythmia. Chest pain can also be related to reflux. Palpitations are often more common due to the increase in sort of heart rate generally in pregnancy, and hormonal changes without being related to any arrhythmia, just more of an awareness of sinus rhythm. And as well, obviously being pregnant will increase dyspnea, although again, it shouldn't be occurring at rest or minimal exertion. We also don't want to see any drops in saturations. It's important to know what the patient's normal saturations are, as we do have some patients with saturations chronically sort of in the high 70s or 80s, and that is obviously normal for them. Now, the Royal College of Physicians have quite a useful toolkit on managing acute medical problems in pregnancy, where they quite nicely highlight red flags for each of these quite common symptoms in pregnancy to help identify which patient should be escalated and investigated further. When we look at breathlessness, things that concern us is if patients are suddenly breathless, if they are breathless lying flat, if their breathlessness is associated with pain or syncope, and if they're tachypneic. Obviously, this guideline is for all women, so they've got a saturation of less than 94% to be concerned about. But obviously, with our patients, it's more a drop from their baseline. When looking at patients who present with chest pain, obviously those in severe pain requiring opioids are of a concern. Pain that sounds ischemic in origin, so pain that goes to the shoulder, to the arm, the back of the jaw, anything that gets worse when they walk, anything they describe as tearing or suddenly occurs, and especially if it's associated with symptoms of sort of coughing up blood or being more breathless or blackouts, or abnormal neurology. So if a patient was to have a dissection and it then the dissection moved up into the blood vessels that go up to the head and neck, they can have symptoms similar to a stroke. If the dissection is lowered down in the aorta, it can affect the blood supply to the legs and cause weakness in the legs as well. Palpitation is often a difficult one to assess in pregnancy and is very common, but anyone with a family history of sudden cardiac death is always a concern, as well as palpitations in patients with known structural heart disease, which is often why we do see these patients referred in with their symptoms. Again, any associated cardiac symptoms along with the palpitations again raises a suspicion of underlying pathology and therefore should be referred for review. And the potential acute emergencies are things like arrhythmias, so whether they come from the top or the bottom chambers of the heart, patients who go into heart failure, aortic dissections, and obviously mechanical valve thrombus when you get a clot on a metal valve within the heart. And I'm now going to just go through some cases of patients from the last few years who have sort of presented in pregnancy with issues. I know obviously this setup isn't the best for sort of being interactive, but if anyone does have any comments or questions, obviously please do put them in the chat, and happy to go through them as well. So the first case that I chose was the 28-year-old patient who was born with pulmonary stenosis and an atrial septal defect. So pulmonary stenosis is a narrowing of the pulmonary valve. So that's the valve that separates the right-sided pumping chamber and the blood that travels to the lungs. And it is quite commonly associated with other congenital heart defects, and often an atrial septal defect, which is the hole between the two collecting chambers at the top of the heart. And for this condition, this patient had had a balloon pulmonary valvuloplasty when she was 3 months old. So they would have accessed the blood vessels at the top of the leg. They would have gone through the veins up to the heart into the right atrium, crossed through into the right ventricle, crossed the valve, and then inflated the balloon in order to stretch the valve and then improve the blood flow to the lungs. When this patient was 18, she then returned, and we put a device in the hole in her heart, again by accessing those blood vessels in the top of the leg. But when she returned for follow-up, we knew that there was a small residual hole, so the device hadn't fully occluded the whole defect, and there was evidence that blood was going through this hole in both directions. So we weren't able to close this because the fact that it is travelling across in both directions highlights that there is an increase in pressure on the right side, and if you close that, it will actually make the pressure worse, and the patient will actually be more unwell. This is a patient who had a successful pregnancy in 2017. She was given prophylactic molecular heparin to reduce her risk of paradoxical embolism because of that ability for the blood to travel from the right side to the left side through that residual hole. And so when she got pregnant in 2020, we did exactly the same thing. However, she called an ambulance when she was about 32 weeks pregnant because she had suddenly developed chest pain. It was central, very heavy. She was very sweaty, felt unwell, pain going down into the arm. And she had this ECG performed at the time, which hopefully you can identify that she has some T-wave inversion in the lateral leads. She came obviously appropriately to hospital with the ambulance. Her troponin was over 1,000, and she was diagnosed with a non-SD elevation myocardial infarction, so a heart attack. She underwent an angiogram, so we had a look at her coronary arteries, but they were all normal. And she'd had an ultrasound which showed that this hadn't affected the strength of the heart muscle at all. So the presumed mechanism was that a clot had travelled from the leg, so as in a small DVT, had sort of travelled across the hole in her heart and has then gone down the heart arteries and had since cleared. On speaking to her, she admitted to have not taken her injections, which was obviously discussed with her. And as a result of this event, she then was escalated to full dose low molecular heparin for the rest of her pregnancy and delivered uneventfully following this. So just to highlight, the ischemic sounding pain that women can get when pregnant can still be investigated as the same as patients who aren't pregnant in terms of having an angiogram and being assessed as needed and managed appropriately with full anticoagulation. And she's not had any further children since. The next case sort of separate that I thought I'd go through was the Marfan syndrome patient. So this patient was 42 years old. So Marfan syndrome is a condition that can affect multiple systems within the body. So they are generally very tall in stature. They often have some chest deformities. So the pectus excavatum, so it's almost like a scooped out sort of appearance of the chest wall, anterior chest wall. They're known to have heart conditions, but also it can affect the spine and can affect the eyes as well. And And this patient had already had 3 uncomplicated pregnancies and was pregnant for the 4th time. So she was under our care with follow-up and was known to have dilatation of her aortic root. So this is the picture of her echo. So you've got the, I haven't got the pointer on here, sorry. Not the pen, sorry, so a pointer. So this is the left ventricle here. So this is the main pumping chamber of the heart, and this is the aortic valve, and then this is the aorta that carries the blood away to the body. Hopefully you can appreciate that this root is bigger than higher up on the blood vessel. So this was measuring 42 millimeters. Ideally, we like it to be below 34, but it does sort of get indexed for height. So obviously taller people are allowed a slightly bigger blood vessel than very short people. She was on bisoprolol, as we know that this can help to reduce the progression of dilatation, so slow the increase in size of the blood vessel, as well as having the added benefit of controlling blood pressure. And she was delivered by an cesarean section, very uncomplicated. Now, with patients with Marfan syndrome, the concern is always the risk of dissection, and we therefore keep patients in for 5 days for monitoring. And she remained an inpatient without any issues. A few days after she delivered her child, the baby had an unresponsive episode and she was breastfeeding, and the bisoprolol was stopped due to potential concerns with regards to whether this may be contributing to a sort of bradycardia or hypoglycemia in the neonate. So she went home at day 5 and a day later called an ambulance because she had severe chest pain. And this was what we describe as like a tearing pain going through to the back. Again, called an ambulance and appropriately was brought back to hospital. So this is a sagittal view of her imaging, and hopefully you can appreciate. So this is her aorta here, and this is the heart here. And there is a line going all the way down here. You can see it obviously on both views. So this is her dissection that has occurred sort of, I think, day 6 or day 7 postpartum. She had this obviously repaired. She's done very well, and it just wanted to highlight that often with these high-risk patients, we see them so frequently during pregnancy. We get them through to delivery, and there's often a bit of a sigh of relief that, oh, we've got through it, everybody's okay, mum's well, baby's well. But actually, the risk hasn't ended, and especially in patients with aortopathies that are at risk of dissection. The recent sort of guidelines now quote sort of over 60% of the dissections occurred postpartum, which is why obviously we keep them for 5 days. Obviously this one occurred at day 6 or 7. And it's just making sure that patients are very well informed that if they do develop any severe symptoms of chest pain, to make sure that they do seek medical attention promptly and highlight to the emergency department or to the ambulance service that they are known to have a condition that increases their risk of dissection, so that we don't delay getting the imaging and the appropriate treatment. And this patient, say, had Marfan syndrome, but there are other conditions that also increase the risk of dissection. So bicuspid aortic valve, which we mentioned earlier, where the valve is the 2 leaves instead of 3. Some connective tissue diseases such as Loeys-Dietz and vascular Ehlers-Danlos loss, and as well as Turner syndrome, which is where one of the X chromosomes is missing. Now, the risk of dissection does vary and is the lowest in the bicuspid aortic valve, but the risk with the Ehlers-Danlos loss patients is that it's so unpredictable and can occur even with normal sized vessels that we do actually advise against pregnancy in that patient group. For the other conditions, we do often see that the risk of dissection is higher the larger that the aorta is, although this is not always the case, and therefore the current guidelines do assess risk based on the size of the aorta. And again, it's another important reason for pre-pregnancy counselling, planned pregnancies, and the ability to have up-to-date imaging before a woman becomes pregnant. Now, the reason that the aorta struggles more in pregnancy is often due to the curvature. So the image here is what your aorta looks like when you're not pregnant, sort of a nice straight line. And as to be expected, once you're pregnant, the thoracic contents become squashed upwards by the diaphragm, and it results in the aorta becoming a more curved in appearance. Now, by changing the curvature of this blood vessel, it changes the stress on the wall, increasing the risk of dissections, and that can be then further increased in terms of risk if this blood vessel is already bigger than it should be. It's worse if there is aortic stenosis, so if the jet coming out of the heart is at much higher speed and hitting the wall at speed. And obviously if the patients have high blood pressure as well, so lots of sort of different factors to consider and try and reduce any any risks that you can regarding that. Moving on to a third case, this was I think the beginning of this year now, of a 33-year-old who presented rather late in pregnancy to our clinic at 38+4. She was actually known to her local cardiology team with a bicuspid aortic valve, being diagnosed about 12 years ago. There was some mild to moderate leaking through the valve, which is very well tolerated and isn't something we would be concerned about during pregnancy, therefore was being appropriately managed locally. And she was due her routine review, an echo, when she just happened to be pregnant. So she went for her ultrasound scan and was noted to have a high blood pressure. Her echocardiogram, so I think that's on, it won't start. Her echocardiogram is shown here. So this here, I have to put the pointer back on now that I've started it, sorry. This here is the aorta. So this is that main blood vessel that leaves the heart. You can see that where it's black, it's nice and open, and then it sort of disappears. And with the colour flow, you can see this sort of turbulent area here where that narrowing is. With regards to the Doppler tracing, what you can see is that the blood is having to travel very fast to get through that area because it's narrow. And normally you have quite a sharp point, and then it returns to baseline. But because it's taking longer to get through, the flow continues through diastole as well. And the other point when you have sort of narrowing in that blood vessel is that the flow in the aorta and the abdomen also changes, and instead of being nice and pulsatile and doing zigzags, it's sort of a lot flatter with a lot less variation. So this patient then went on to have an MRI, I think the next day or two, and this here highlights that really tight narrowing. So this is the heart here, this is the aorta, so where the blood leaves the heart to go around the body, the blood vessels going to the head and neck, comes around to go down to supply the lower body, and this here is obviously a very tight narrowing. Now, we didn't have a huge amount of time to plan for her delivery. By this point, I think she was already 39 weeks. So initially we discussed the options with her, and we opted to go for an induction of labour with a low cardiac output delivery, so therefore reducing the duration that we would allow her to push, ensuring that she had an early epidural. But then she came and the baby was breech, and we decided we would just do an elective cesarean section instead. And she returned actually very recently to have a stent put into that blood vessel. So to increase the size of the blood vessel and therefore reduce her risk if she was to have a second pregnancy in the future. Moving away from the aorta, for this case, this is a 31-year-old who had endocarditis. So that's an infection within the heart. So, and in this case, it was on her mitral valve, and that was back in 2013. And after completing her antibiotics, she went on to have a mechanical mitral valve replacement. It's quite common after that type of operation to have problems with the electrical conduction within the heart, and she ended up needing a pacemaker because she went into complete heart block, and so she was completely dependent on this pacemaker going forward. She already had 3 children before her endocarditis, and then she had a subsequent 2 after her mitral valve replacement. One of those pregnancies, she had developed a clot that had gone down one of the heart arteries, causing a heart attack. So she already was quite aware of the high risk of any pregnancies. So it surprised us when she presented at 34 weeks to her local emergency department because she had some chest pain, reporting that she wasn't aware that she was pregnant. She was on warfarin, although her compliance had been pretty poor, and was converted onto low molecular weight heparin by the team locally, and referred down to Leeds for us to see her. So one of the concerns with regards to mechanical heart valves is that patients with a mechanical heart valve need to be on lifelong blood thinners, and this has to be warfarin. We cannot use the newer agents, such as a Pixban or a Doxaban. And if a clot forms on one of these heart valves, it's incredibly serious. It can be life-threatening. If the valve is blocked by a clot and it can't open properly, or if a clot forms and it flies off and it causes a stroke or a heart attack, or it could go down one of the limbs and occlude sort of blood flow to a limb. So it is a potentially very, very serious complication. And as we know, pregnancy is a prothrombotic state, and it's quite difficult to have the perfect anticoagulation strategy in pregnancy. With regards to warfarin, this is the most effective for the mother, and actually the newer guidelines from a couple of months ago, European guidelines have started to say that for the higher risk patients, potentially consider keeping warfarin throughout. But for the time being, we do still convert to low molecular weight heparin for the first trimester, as it doesn't cross the placenta, and we know that warfarin can affect sort of development of the fetal organs. But heparin, we know, isn't as effective in anticoagulation as the warfarin. The other thing that is an issue in pregnancy, obviously, the anticoagulation will increase the risk of bleeding at the time of delivery. And anyone who is on warfarin during pregnancy, we do convert to heparin for about 36 weeks onwards in preparation for delivery. With regards to sort of experience of mechanical valve pregnancies, this audit was a couple of years ago when we looked at sort of 14 patients who'd had 21 pregnancies between them. Each line on that graph on the left here is a pregnancy. If the line is blue, it resulted in a live birth. If the line is black, then sadly there was a miscarriage or intrauterine death. And then the stars are for complications that occurred. So the yellow ones, if a thrombotic complication occurred, and the red, or if a hemorrhagic complication occurred. As I say, there were 21 pregnancies, 16 live births, and one of those was a twin pregnancy, which was particularly stressful for us. There were 2 first trimester miscarriages and 3 second trimester miscarriages or intrauterine deaths, and 1 opted for a termination of pregnancy because they presented acutely with a valve thrombus at around sort of 17, 18 weeks gestation. Only 38% managed to get to term in terms of gestation. And with regards to the complications, there were 6 thrombotic and 6 hemorrhagic complications. So when you look at this in total, of the 21 pregnancies, 29% ended with a live birth with no maternal complications at all. And if you then look at those with no complications and managed to get to term, it was only 19%. And these outcomes were quite similar to those that have been reported sort of nationally and the European registries as well. And when we sort of talked about anticoagulation, when we change people to low molecular weight heparin, we obviously calculate the dose based on their weight, but it can be quite difficult to predict their response. And this was a different audit we did of all the anti-10A levels during pregnancy. And as you can see, they are not very well correlated between the lines. So only 45% of them were actually within range. And since this audit was done, the newer BSH guidelines came out, and we now do start at a higher dose from the first presentation than we used to. And I think it'd be quite useful for us to re-audit. And I think we're going to have a lot fewer of these lower readings at the beginning of pregnancy. So this lady came to see us in Leeds, and this was her echo. So this is a Doppler through her mechanical mitral valve replacement. So what we're looking at is sort of the mean pressure gradient. So this reflects how easy or hard it is for the blood to go through the valve. And the value here should, ideally be sort of less than 5. And when she first presented, it was 12 to 18, and she had a very low anti-10A level, indicating that she wasn't appropriately anticoagulated, on the background of not really being appropriately anticoagulated during pregnancy. But at that time, she reported feeling absolutely fine with no symptoms at all. We brought her back 2 weeks later, and it had gone up from 12 to 14 up to 18 to 20. So by this time, she was already about, I think, 36 weeks gestation. And we decided, after a long MDT discussion, that we would, and discussed with her, the best thing would be to deliver her via C-section. As I say, this, I think, was her 5th child now, and discussed contraceptive options with her. She did agree to have a tubal ligation at the time of her section. But because of our concerns regarding the mitral valve, her caesarean section was performed in cardiac theatres, and we did both the caesarean section and the redo mitral valve replacement on the table during the same operation in February. And as you can see, there was an awful lot of clot, highlighted by the arrow, on the valve, which is why it wasn't obviously opening as well as we'd like. She did remarkably well, considering how concerned we all were for her safety. Unfortunately, we have not seen her since, because she hasn't been attending clinic. So we're just hopeful that she's at least continuing with her warfarin locally, and hope that she doesn't present acutely again with further valve issues. So obviously, things that we've just sort of discussed is, pregnancy does stress the heart. We're all aware of the normal physiological changes, and having congenital heart disease on top of that does sort of pose extra additional risks. And these risks can vary by lesion and sort of by physiology. That's why sort of MDT planning is so important, and allows us to have the best outcomes that we can achieve. And why it's obviously important to know the red flags, symptoms to be concerned about, when to escalate and how to escalate, and who needs to be aware. So thank you very much for listening. So I'm happy to take any questions if there are any in the chat. Hopefully that's been helpful.
Fantastic. Thank you, Ellie. Yeah, you've certainly generated quite a lot of discussion in the chat. I know that Kate Gatenby has already answered quite a few questions, but
thank you, Kate.
I guess quite a lot of questions about aortic dissection, relating to sort of things like coarc repair and repair. If you've had a repair of your aorta, what is the dissection risk in pregnancy, I guess, is kind of the theme of some of the questions.
So in part, it depends on the repair result. So are there any residual issues? So is there any residual coarctation? Is there any evidence of dilatation of the aorta either before or after the coarctation repair? Are there any sort of pseudoaneurysms or outpouching? Do they have hypertension, or is their blood pressure well controlled? So we would obviously review each patient individually, but even if someone has had a really nice coact repair with no issues, we do still just explain to them the risk of dissection. We say it's less than 1%, you know, it's a rare risk, but we do deliver our repaired coacs in Leeds in a cardiac surgery centre for that small but still acceptable risk compared to the general population.
Okay, and then I mean, there are people that have had aortic root replacements, aren't there? And for things like Marfan's syndrome, what do you tell those patients?
So our outcomes after the root replacements have been very good. When you look at the literature, there's not as much about it, so we still treat them as though they were high risk because we explain to them we don't have the evidence that they're not. But we say from the small numbers that we've seen so far, we've had very good outcomes and we haven't had any issues. But we still do see them regularly in clinic, and at the moment we do still deliver them here. We also explain for those with connective tissue diseases, and Marfan's, Lois Dietz, things like that, even if you've replaced the root, there's still the risk of other areas dissecting.
Dissection,
dissection in other areas. So being monitored and having that education of things to look out for is just helpful to make sure that they seek urgent attention, because a lot of these patients, they come to clinic and we say they have no symptoms and nothing has changed on their scan and everything is fine, and there's nothing we can do unless something happens, if that makes sense. It's either everything's okay or they've dissected. And it's just making sure that they're educated and empowered to push and advocate for themselves if they have any symptoms, so that they get care quickly if it happens, really. So we do still manage them in our clinic as high risk, even though we know the risk is lower.
Yeah, it's that message, isn't it? I think that if you're getting sort of central chest pain, sort of stabbing, going through the symptoms and education of the patient, so important. And certainly in our experience, we've given that advice to someone and they've followed that advice, and then they did have a dissection. So it sort of proves that it's really important to educate the patient and other sort of people looking after the patient, that those symptoms are to be taken really seriously, I think. I think there were a few questions about the patient who did dissect and on stopping bisoprolol.
I don't think that made a difference.
No, okay,
No, it was. I just put it in because it was part of the history. But I don't think not being on bisoprolol for 2 days will have
made any difference.
Any difference, although it did make us reflect. You always question it, don't you? Had they stayed on, it would have made a difference, but a low dose of beta blocker. It's more to do, the beta blocker evidence is about the progression in size as opposed to the sudden dissection, if that makes sense, I think. But I suppose we'll never know. But it's unless I can't actually remember if when she came in there was this much bigger blood pressure than when she left. I can't remember off the top of my head. Sorry.
No problem. So I'm just sort of reading through chat as well. What's the risk of fetal bradycardia for patients on bisoprolol? Wouldn't say it's a problem myself, but no. I don't know whether you need to take that question.
So, I mean, we give a lot of beta blockers, and historically, obviously, patients we were concerned about beta blockers and the risk to the fetus in terms of growth restriction, bradycardias and hypoglycemia. From speaking to sort of obstetric colleagues when we're in clinic, the issues with regards to the smaller growth, my understanding is that now it's not the beta blocker, it's the reason they're on the beta blocker. Is the reason why will affect
I think
fetal
I
growth.
think that's true. I think it's almost certainly confounding. So it's not really necessarily the beta blocker, but the reason why most people are on beta blockers is sort of coexisting hypertension or coexisting heart disease, and it's quite difficult to unpick the effects of those versus the effects of the drugs. I did have one patient that was quite worried about the effects of beta blocker on sort of fetal monitoring and things, and that was quite an interesting sort of question that I hadn't actually considered before. But I don't really think that we see kind of the fetal heart rate slowing in particular in patients with beta blockers. And as you say, there are a lot of patients on labetalol for hypertension, and it doesn't really cause an issue. So just sort of, I don't think it's a problem. But yeah, it was an interesting question, I think.
No, absolutely, yeah.
Great, okay.
And I think there's just one more question about which beta blocker you would use. Is there a preference?
So I suppose it depends on the indication for it. So if for the patients with Marfan syndrome or sort of arrhythmias, we tend to go down sort of more the bisoprolol route. If it's hypertension issues, then we go labetalol in our clinic. But I don't know if you do separately, Kate or Ken.
Yeah, no, labetalol almost certainly for hypertension and almost never for any sort of arrhythmia or anything. And yeah, as you say, bisoprolol or metoprolol or something like that for more cardiac indications.
Yeah. I was just seeing if there were any other questions. Sorry, I was trying to go through them. I think Kate's actually sorted it all. Thank you, Kate.
So
But yeah, I think that's everything that was on the chat, isn't it?
it is, I think. Yeah.
We can unmute as well, Ken, if anybody does want to pose a question at this point before we go on the break.
Yeah, if there's any last questions anyone's got about any of the cases or any questions you want to pose to Ellie or Kate.
If the patient did not.
Do you use and how to monitor anticoagulation?
So, yeah, so with this patient, our concern is that she's now had 2 pregnancies complicated by thrombotic complications. So, I say with the newest ESC guidelines, they've started to discuss whether, talk about whether you would just stay on the warfarin throughout and not convert to low-molecular heparin. We often find that the most common time for thrombotic or hemorrhagic complications is when we're converting from one to the other. So I think if she was to be pregnant again, we would have that discussion with her about continuing warfarin throughout, even though we know it crosses the placenta. I suppose sometimes with the warfarin, people can home test their INR now. It's much more convenient. I remember she lives a very long way from Leeds, and we always have concerns with her compliance with her anticoagulation and attending for anti-10A levels and things like that, as well as injecting twice a day. I do wonder with her in particular whether we would talk about staying on the warfarin, but as of yet, I think she's not gone for her 6th child yet.
Yeah, there's another question, follow-on question to that. Do you find INR is more unpredictable on warfarin when pregnant?
I think we often find it as in it can vary. People who used to be on the same dose of warfarin for years are having to make adjustments. But it's very easily monitored and adjusted and responds. So yes, but manageable, I guess, is would be the response. I don't know if you find the same, Kate, if you use it much.
No, we're not using much warfarin in our patients, Ellie. We'll give them all to you.
Oh, thank you.
I guess I just have a final question. So we've been seeing increasing numbers of patients who've had sort of pairs procedure where you kind of wrap a cuff around the aorta for things like Turner's. What's your counselling for those patients. So I think we had a particular patient, I guess, that was high risk and then has had this pairs procedure. Well, we weren't sure what to say about the pairs procedure in terms of risk of dissection.
Absolutely. So we have also had one very similar recently. So had the pairs procedure down in London for Marfan syndrome. And I suppose that the taking point from that was that she went into her operation thinking she was doing that to become risk-free. And therefore it was quite difficult conversation for her to acknowledge that she was not risk-free. She was lower risk, but not completely, still higher risk than the general population. We spoke to the team down in London as well regarding it. So they've basically said without it, she would have had, they said, a 10% risk of dissection, and they said they've reduced that down to 5%. So that's what they had told her. So we've given her the same numbers. So it's reduced her risk of dissection in that area, but not potentially elsewhere. And they have had, I think it's 6 or 7 pregnancies now post pairs from the London Centre. They've had no dissections. They've had all good outcomes from a maternal point of view, which again I've explained to this patient. Again, you've got these sort of 7 women who've had a baby, a pregnancy post pairs, and they've all had a good outcome and no one's dissected. So the early evidence is promising, but again, it's very low numbers.
Still low numbers,
but still low numbers, but we know that your risk is lower than it would be had you not done this. But because the risks are still unknown, we will treat you as though you are high risk, and we will monitor you regularly in pregnancy, and we will deliver you in a surgical centre. And, whilst I think she'd hoped her risk would have been lower as a result, I think a lot of women are quite happy to be monitored closely during pregnancy and be managed as though they were high risk, even if they feel we're being a bit overkill.
Kate?
The only thing I was going to say about that, Ellie, is that I know we share the aortas. We see a lot of women who've got inherited aortopathies with normal aortas, and or at least have family histories, or maybe they're in the process of having gene tests. And the sooner we get to see those so that we can educate them, the better, because it's often quite late in pregnancy that we'll end up seeing them. And then as Ellie suggests, we think that they are higher risk, but that risk is a bit unquantified, because number one, they may not have the gene anyway. Number two, often they've got normal aortas, but we still, because of the sort of the catastrophic consequences of dissection, usually suggest a degree of caution. And if you've had a woman who all the way through pregnancy has believed that they're going to be able to have a home birth, and they turn up at 32 weeks with a family history of an aortopathy, we probably will counsel them against having a home birth. And like Ellie said, having a delivery in a surgical centre, which does have some other complexities if you are 30, 40 miles away from that surgical centre. So the sooner we see them, the better, so that we can start having those conversations.
Yeah, great, thank you. One final question, I think, just before the break. It's a good question from Nicholas Child. Are warfarin safer in pregnancy at low dosage?
So one of the guidelines does sort of separate warfarin dosing and risk as to whether it's above or below 5 milligrams. There has been it was interestingly not really mentioned in the newer ESC guidelines, the same table, because I looked for it again. But in the previous guidelines, it was a nice table that said if you were needing less than 5 milligrams or less of warfarin to maintain a therapeutic INR, then that was deemed to be lower risk to the fetus than if you were needing greater than 5. And if you were needing greater than 5, that you would consider more low molecular weight heparin. But as I say, interestingly, when I was reading the newer guidelines, that table has disappeared. So I don't know if that's sort of been superseded, but it wasn't mentioned. But yes, in theory.
Yeah, I think it's just kind of one one study from Italy, was it, with about 160 people in it, I think. That's where the data comes from.
Yeah.
It's not a hugely powered study, I would say. And it probably wasn't methodologically sort of it wasn't sort of designed to test that sort of dosage and cutoff. So it's just that sort of chance finding on a study, I think, and it may well be it might be a true finding, or it might just be a sort of chance finding. I don't think it's sort of statistically robust myself, but there is that.
It's what you class as being safer. So we've had, there's the risk of embryopathy to the fetus, but then we've also had a patient where we've converted the mechanical valve pregnancy. We've converted them back to warfarin after about 14 weeks, and then they've had an intrauterine death. And some of those, I think, the ones that we'd had, I think maybe two of them ended up being attributed to warfarin due to like intracranial hemorrhage in the fetus. So it's what you deem as being, what's your definition of being safe? Is it safer for the mother, or is it safer for the baby? We know that warfarin is safer for the mother. It's the fetal risk, and we often do have that that discussion, and that's why the MDT is useful, because you've got the fetal, from your side of things, obstetrics, and focusing on fetal, and ours focusing on the maternal risk, and balancing that. And each woman and each patient views risk differently, and it's all about just explaining those options and seeing what they feel is right for them. And I say we've had ones where they've had poor outcomes, where they try the opposite way the next time.
We've certainly had that, where someone's had a kind of a bad experience, let's say on warfarin, either lost a fetus or something, and then next time very reluctant to kind of be on warfarin. So you see that sort of association, don't you, with the patients. And the other thing to say, I think, is it's true that the baby is more anticoagulated with warfarin than the mother sometimes. So you can, even though the mum's might be sort of therapeutic INR, the baby might be more than that. And there is this, it's not just about congenital anomaly, but also about sort of fetopathy and intracranial bleeding and things in the baby. So I think it's probably a bit too simplistic to sort of say that there's a sort of safe dose of warfarin, because I'm not quite sure that that's true. Great. Good. So anyway, I think probably it's time for us to call an end to this session. And I think we now have a short break. I'm just trying to find on my computer when that...
Yes, that's right, Ken. We should be back at 2:25. But I think there's a question in the chat that you might want to have you could probably best to answer if you want to reply in the chat. But yes, we'll come back at 2:25 if everyone's happy with that.
Thank you very much. Okay, so you're ready to go.
Yes, I am. Can you hear me all right?
Yeah, good. So
give me a second. You're coming through my...
There we go, try that.
That sounds good, yeah.
Lovely. I've just had a worrying low battery on my earphones thing, so we'll see how we get on. It may be that you're going to be using a different microphone.
Okay, well, it's with great pleasure that I introduce Kate Gatenby, who is a consultant cardiologist from Leeds General Infirmary, who subspecialises in heart failure, echo and obstetric cardiology. And this afternoon is going to be talking about hypertension in pregnancy.
Thank you very much, Ken. Although this is a North East meeting, at least two of us are in London. I've just noticed one of our colleagues is also on the meeting, who's to my right in the hotel in London that we're in, waiting for another meeting this afternoon. So a pan-England meeting. So I'm going to be talking to you about hypertension in pregnancy. We're going to talk a little bit about pre-pregnancy care, and I'm actually going to focus a lot on the management of chronic hypertension in pregnancy, because I realise that for many of you, managing gestational hypertension is your daily work. And there are a lot of commonalities between managing women who have got hypertension before pregnancy and women who develop hypertension during pregnancy. And I'm also going to focus a little bit on what it means for a woman's future if she has hypertension, either before or during pregnancy. I do not have an eye on the chat at the moment, so if someone could keep an eye on it. My bias in this is that obviously all of the patients that I see who have hypertension are in hospital, and they're in hospital usually for reasons that they're not very well. So I'm going to illustrate the importance of managing hypertension appropriately with a case which is a relatively complex case and one that's got a few additional complexities to it. So in 2023, we first met a 36-year-old lady who was not called Janice, but for the purposes of this, she was called Janice. She's gravid of 5, para 3. She'd had hypertension in previous pregnancies and had not been on any medical therapy since. Indeed, she didn't remember having her blood pressure checked after any of her other pregnancies. She presented to her local services when she was 9 weeks pregnant, at which point she was fairly unwell. She was breathless. She had marked hypertension of the systemic blood pressure of 160 over 110, and at that point she had a clinical syndrome of heart failure. Her NT-proBNP was high, and she had severe left ventricular systolic dysfunction on echo, and there were quite a lot of markers on her echo that suggested that she had hypertensive heart disease. And it's beyond the scope of this talk for us to talk about that, but she had left ventricular hypertrophy, which is something that you get when you've had hypertensive remodeling. She was referred through to our cardio-obstetric clinic, where we saw her just after her admission. At clinic, she was still significantly hypertensive despite having been started on bisoprolol. She was fluid overloaded and in decompensated heart failure and had a really high systemic blood pressure. So we admitted her, we controlled her blood pressure. And at that point, we talked quite a lot with her about her options, given her severe decompensation early on in pregnancy. During this pregnancy, at least, she elected for a termination. Shortly after this, we initiated heart failure therapy. We counselled her a lot about considering further pregnancies, certainly at that stage. I'm going to tell you a little bit more about Janice in a bit. When we're thinking about hypertension in pregnancy, roughly speaking, we can divide it into 3 or 4. It depends a little bit on which guidance you look at, sets of women. There are women who have chronic hypertension. So that's people who are hypertensive before they start off being pregnant. So hypertension that develops before 20 weeks of gestation, and it persists for 6 weeks postpartum, and it can or cannot be associated with proteinuria. You can get gestational hypertension, of course, which develops after 20 weeks of gestation and usually resolves within 6 weeks of postpartum. You can get women who you don't know. So blood pressure might be first recorded after 20 weeks, but it's unclear whether or not they've got chronic hypertension. And then obviously the big daddy of all of these, gestational hypertension, accompanied by new onset proteinuria or maternal organ dysfunction. And that can be renal or liver or coagulopathy or cardiac dysfunction associated with uteroplacental dysfunction. So that, of course, is preeclampsia. And as I said, I'm not going to touch too much on preeclampsia, actually, because I think by talking about chronic hypertension, Number one, a lot of that is modifiable before pregnancies, or at least before next pregnancies. And there are lots of commonalities about the things that we should be saying to these women about the risk, and about how we manage their lifestyle and factors like that. So, why is hypertension in pregnancy bad? Hypertension in pregnancy is bad for mum and for fetus. There's a significant increased maternal risk. I'm going to go on and kind of quantify that in a moment. But of course, hypertension, and that's whether or not you have chronic hypertension or gestational hypertension, there's a significant association with preterm delivery, with growth restriction, with neonatal intensive care stay. Women are more likely to need a cesarean section. Obviously, some of that is because of the necessity to deliver some babies at early dates because of poor growth. And we know that hypertension, or women who develop gestational hypertension or indeed have chronic hypertension, this has a long-term effect on many facets of cardiovascular health going forwards. So why is it important? Well, if you look at hypertension in pregnancy, there's numbers of different estimates about how many deaths it might be responsible for, but it's probably responsible for around 50,000. That may be a conservative estimate of deaths per annum in pregnancy. So that's around 15% of deaths in pregnancy worldwide. And you'll notice from the picture on the right-hand side that there's a predominance in sub-Saharan Africa, in some parts of the Middle East and in Mexico. So we know that women who are in lower socioeconomic groups are more at risk of developing hypertension, both chronic hypertension and indeed gestational hypertension. And there's been a significant increase. So with some centres suggesting that this is increasing twice-fold between, I think, about 1993 and the early 2000s, and is likely to increase further. And it's increasing because of increasing maternal age. And these are factors that increase your risk of developing chronic hypertension, and they all increase your risk of developing gestational hypertension as well. But the older you are, the more likely you either have to have pre-existing hypertension or develop hypertension during your pregnancy. Obviously, obesity, pre-existing metabolic conditions. So we're seeing an increasing number of women who are entering their first pregnancy with hyperlipidemia, with type 2 diabetes, with metabolic syndrome. As I've already mentioned, there's societal and lifestyle factors that increase the risk of developing hypertension. So being sedentary, we know that people, as I said, of lower socioeconomic groups and certain ethnicities are at higher risk of developing hypertension. And that may even go some way of explaining why certain ethnic groups are at significantly increased risk of maternal mortality. We know that obviously there's a higher number of pre-existing chronic hypertension, and maybe infertility treatments are affecting hypertension rates in pregnancy a little bit. But I think it's definitely the first 5 that are the most important when we're thinking about the significant burden that hypertension is playing on the women of the world. If you look at some studies in America and you look at the people who die during pregnancy, around a third of them have hypertension. I think it might even be more, have hypertension listed as one of the potential contributing factors to that death. So we're looking at a really important set of patients. As I said, I'm going to spend quite a bit of time talking about what happens to women before they get pregnant, because if we can help them before they get pregnant, or indeed before they get pregnant again, we're going to be able to modify their risks. So as I said, about 8% of women of reproductive age are hypertensive, and the incidence of hypertension in women of reproductive age has increased between sort of 1993 and 2002 twofold, and it will have gone up even further. It complicates, so this is chronic hypertension, it's not all hypertensive diseases of pregnancy, it complicates at least 3 to 5% of pregnancies and is probably increasing. The different colours on this chart represent different ethnicities, so the rates are increasing differently in different ethnic groups. As we've already mentioned, these are the reasons why people develop hypertension. They are, whether you're developing hypertension in your 60s or whether you're developing hypertension in your 30s, they are all risk factors. So how shall we manage these women? I think this would be my general principle for managing women who have hypertension before they get pregnant. And ideally, you would like to suggest that women who have hypertension before they get pregnant should probably have some preconceptual counselling, although I realise that's slightly blue sky. We know that they have a cardiac risk assessment. We now have a cardiac risk assessment at booking. And you would hope that that might pick up women who've got hypertension. And for people who have had so for people who have had moderate to high risk hypertension, so that's either very severe hypertension or hypertension that was poorly controlled, and I'll go on to define that in a minute, before they get pregnant, probably some early specialist review, and it needn't necessarily be with a cardiologist. It could be with maternal medicine, who are going to be really focused on trying to ensure that right women get the right treatments to modify blood pressure, and think about other things that you can do to reduce the risk of preeclampsia. So, for example, making sure they get aspirin at an appropriate stage. So what does that look like? Well, for a start off, if you're seeing a woman before she gets pregnant and she's hypertensive, they need lifestyle advice. Weight loss, smoking cessation, exercise, and diet are all very important. Ideally, you would want some idea about cardiovascular risk assessment using one of the risk assessment tools. And generally, control of blood pressure with medication suitable to take during pregnancy is a really important thing. And it's one of the things that I would do if I was seeing someone before they got pregnant, is I would try and switch them onto medication that would be suitable to take during pregnancy, and indeed try and control their hypertension. If you've got chronic hypertension before you get pregnant, there's around a 10% chance that you're going to have a secondary cause. Talk about those in a second. And the other thing that's really important is whether there is any end organ damage, because if you just have hypertension, that is a risk. If, on the other hand, you have hypertension and as a result you've developed proteinuria and you've got left ventricular hypertrophy, then those will modify that risk significantly. And I think it is worthwhile explaining to these women that they are at higher risk. They're at higher risk of fetal complications, they're at higher risk of maternal complications. The slight confounding factor is that there are different ways and different sort of levels at which you might call blood pressure elevated. This is the new ESC hypertension guidance, and you'll notice that there is this number in the middle, which is elevated blood pressure. So those are people who probably have a risk, but do not necessarily have hypertension. So hypertension or chronic hypertension is defined as an office blood pressure of over 140 over 190, which is actually fairly similar to the definition of hypertension during pregnancy. But we do know that people who've got, in inverted commas, elevated blood pressure risk do have an increased risk going forward, and probably they have an increased risk of developing hypertension during pregnancy. So it's probably a larger problem than we believed it initially was. When we're thinking about screening people for secondary hypertension, we often focus a lot on pheochromocytoma. So I've never met anyone who's had a screen for secondary hypertension who hasn't had a urine metanephrines. And the incidence of pheochromocytoma in this population is vanishingly small. But actually, making sure that people have obesity managed and sleep apnea. Sleep apnea is a massive cause of secondary hypertension, and that renal disease is diagnosed and treated, and that if you don't have renal disease and you don't have a coarctation, that actually the commonest secondary cause of hypertension is primary hyperaldosteronism, that's probably a more useful thing to look for than a pheochromocytoma, even though everybody gets looked after a pheochromocytoma. So there are some things that it might be worth thinking about before pregnancy. So what are the general sort of goals? Well, actually, there isn't really any hard and fast rules about what blood pressure goals should be. It's probably around 140 over 80. There's no very good evidence that either using lower levels pre or indeed during pregnancy are associated with better risk. However, my personal thought, and I think Ellie alluded to it in her last talk, would be that you might try and aim for a lower blood pressure in people who've got higher risk. So people who've had previous preeclampsia, people who've had dilated aortas, people who've got chronic renal disease, or they've got left ventricular systolic dysfunction. I would probably try and aim for a lower blood pressure than that. Understanding obviously that will determine placental flow, so you don't really want to go very much lower than 80 diastolic. The interesting thing is that we know that if you have mild to moderate hypertension that is untreated before pregnancy, then actually those women's risk of developing those pregnancy-associated complications is higher than women who started off with severe but have got controlled high blood pressure. So just a sort of a word of warning of beware of the woman who has a blood pressure of 150. It's almost certainly going to get worse, and their risk will be higher than someone who's got beautifully controlled hypertension, even if it started off higher. So outside of pregnancy, there is an increasing pressure for us to use, and probably very well evidenced pressure for us to use combination therapy. So for women outside of pregnancy, dual combination therapy is what the ESC are recommending. It's what the new West Yorkshire Health of Heart's hypertension guidance is going to be recommending, that people are started on low doses of 2 classes of medications simultaneously. However, those 2 classes of medications are likely to be medications that you can't take during pregnancy. So as Ellie said, ACE inhibitors, angiotensin receptor blockers, thiazide diuretics are not great during pregnancy. So you may have someone who's got really well-controlled blood pressure on medical therapy that is inappropriate to take during pregnancy. And certainly there is an increasing vogue that we should be trying to rapidly optimise patients who have hypertension. There's a huge amount of inertia at managing people and women who've got hypertension, letting it go on for years and years without it being optimised, and getting women who are wanting to become pregnant in the next year optimised on medical therapy should be something that we do quite quickly. So if you are looking to get pregnant, I would actively look to switch a woman onto a combination of beta blockers, calcium channel inhibitors, particularly nifedipine. You can use methyl-dopa. It's got some side effects. I use quite a lot of hydralazine, but then that's the population of women that I look after tend to have left ventricular dysfunction, and I think hydralazine has got particularly good evidence in that setting. But combinations of treatments are likely to be important. You can also use some diuretics as well. So getting people on those classes of medications before they are pregnant, because they are what you would use during pregnancy. And I know we've had a chat about what beta blockers and various things during the other conversations. As has already been spoken about, labetalol is reasonable for hypertension. If it's just hypertension, any whiff of any cardiac problems, I'll usually be giving people bisoprolol and titrating it up. So how are we going to manage these women intrapartum if they present either with chronic hypertension that's deteriorating, or alternatively they present with de novo hypertension? And I think the first thing to say is that the only way we'll pick these up is with regular blood pressure checks. Obviously that happens very frequently at the midwifery appointments. And it is quite important, I think, to avoid inertia. We know that starting treatment, if you've got blood pressures of over 140 over 90, is important. You can use home blood pressure monitoring, but actually very few of the monitors are validated in pregnancy, and you can have a tendency to overestimate blood pressure using the home blood pressure monitors. And so actually the best validated measure of assessing blood pressure is with a sphygmomanometer. I don't know how many of you would regularly use a sphig to check blood pressure, but it's definitely the best validated method in women who are pregnant. And if you have a woman who's got severe hypertension, whether that's chronic persistent hypertension or whether it's new hypertension, and it is in pregnancy, so beyond 20 weeks, that represents a hypertensive emergency. That needs urgent admission and intravenous treatment usually. We've already talked about this. It's just really to say that obviously if you're on these medications before pregnancy, then you can use exactly the same combinations of therapy during pregnancy. So that's why it's a really good idea to get your women optimized on these therapies before they become pregnant. My apologies, I've obviously changed the name of this woman, but this is the same woman who I was talking about earlier on. So this is Janice, it's not Olivia. Just to tell you a little bit more about her. So in 2024, she'd been initiated on heart failure therapy. She actually had a degree of cardiac remodeling, as you often see with hypertensive heart disease. Her left ventricular dysfunction, which was severe during her pregnancy, actually only became mildly impaired, and her blood pressure was well controlled. And she went through lots of other treatments to see if we could work out why she was hypertensive and why she had heart failure. She was asymptomatic, and she decided she wanted another pregnancy. And we talked to her a lot about this. As you can imagine, we did not think it was a very good idea, partly because we were concerned that removing all of her heart failure therapy would cause adverse remodeling. She actually stopped her medical therapy and she let us know when she was 12 weeks pregnant. She visited us for the first time in the obstetrics clinic again when she was 12 weeks pregnant. She had severe left ventricular dysfunction. She was asymptomatic but had no fluid overload, and she had severe hypertension at that stage. So what did we do? Well, we admitted her. Even though she was only very early pregnant, she was adamant that she was not going to have a termination on this occasion, and we very aggressively controlled her blood pressure over a 4 or 5 day admission. So when she left hospital, she was on good doses of bisoprolol. As I've said, we gave her hydralazine, which I like because there's evidence base for it in heart failure and it's an antihypertensive. And with hydralazine, from a heart failure perspective, we usually use some nitrates, which are also tolerated in pregnancy. And there is obviously a blood pressure there's a degree of blood pressure control with nitrates. She was started on some furosemide, some aspirin, and we actually had her on some enoxaparin, partly because her BMI was elevated and partly because by this point her left ventricle had deteriorated and we were a little bit concerned about the risk of coagulopathy. She had very regular reviews. I think we saw her about every 2 or 3 weeks. We kept her blood pressure very tightly controlled. So we were trying to aim for somewhere between 120 and 140 systolic blood pressure throughout the duration of her pregnancy, which we actually managed to achieve. She developed gestational diabetes. In sort of comparison to her previous pregnancy, she was asymptomatic throughout and her NT-proBNP was low. So although her LV function was significantly impaired, I think managing her blood pressure had potentially helped. She ended up having a cesarean section at 34 weeks for fetal reasons. The baby was growth restricted, and there was starting to be evidence that her placenta was failing, and we reinitiated her heart failure medication post-delivery. She decided not to breastfeed, so that was a fairly straightforward thing for us to do. When we saw her in clinic in 2025, she was on heart failure therapy. She was asymptomatic with a low blood pressure, but her LV was still severely impaired. So this is a lady whose left ventricular function has become impaired over the duration of her pregnancy, and her baby girl, who is a little poppet, is doing very well. And she is using some contraception. It's not a long-acting reversible form of contraception, but she is using some contraception. So what did this make me reflect on? Well, I think one of the things that was really important with this woman who changed from being Janice to Olivia was that she had suboptimally managed hypertension before she became pregnant. She had hypertension during several of her pregnancies and didn't have any long-term follow-up in between her pregnancies. And that almost certainly contributed towards the development of her left ventricular dysfunction. We have taken from this that if you have hypertension and therefore you have high systemic pressures, and the combination of high systemic pressures and left ventricular systolic dysfunction, we now manage very aggressively and we get people into hospital early if they've got the combination of those two things. And I've got some concerns about whether the good outcome in this lady is going to influence her decision going forwards, because she did very well, although her left ventricular function is still very abnormal. I think she's just about got away with it, even though certainly I and Natalie have a few more grey hairs than we had before we started looking after her. So what does hypertension for a woman in pregnancy mean for the future? That's me, that's my daughter, who's now 16. We know that if you have blood pressure that's persistently high postpartum, and it was high prepartum, that you should probably restart medication relatively soon. And part of the reason is that women are very intensively looked after when they are pregnant. And once women are no longer pregnant, apart from their 6-week check and apart from seeing the health visitor, which is predominantly about ensuring that your baby is okay and psychological well-being, I do have some concerns that there is a risk that these women will fall out of medical care. Obviously, you need to just think about whether they're breastfeeding and how that might influence medical therapy and contraception, particularly if it's been a difficult to manage pregnancy and if you've had significant hypertension. What would happen at a 6-week check ideally? I mean, I think ideally, and usually you do have a repeat blood pressure management, and that should really trigger those standard pathways for monitoring and treatment. So if you have an office blood pressure that's elevated, then I would like to think that that woman will go along the usual pathways that might happen for someone who has systemic hypertension. I suspect that isn't the case. Ideally, you would inform women about their cardiovascular risk and explain that this is going to give them some increased risk for further pregnancies. And we should probably do some kind of cardiovascular risk assessment that looks at smoking and lifestyle, although probably Q-risk 3, which is the standard risk score that we use for assessing cardiovascular risk, is not as good in these women, and that's because they're young. I've looked everywhere for what the term healthy lifestyle means, and there isn't any real consensus of what this is, except to say that dietary interventions, so low sodium, high potassium, is probably worthwhile considering. And low sodium, particularly in women who are of Afro-Caribbean background, and that's because a lot of them have, if they're very hypertensive, it's very responsive to salt. Exercise is important, smoking, alcohol, weight. So basically all of the things that you can do to reduce your cardiovascular risk going forwards, because we know that women who have had gestational hypertension or have chronic hypertension, obviously that goes without saying, but if you have gestational hypertension that returns to normal, or preeclampsia and your blood pressure returns to normal, you have a significantly high risk of developing cardiac disease in the future. So what does healthy lifestyle look like? As I said, that probably is what it looks like. So 150 minutes of moderate intensity aerobic exercise, with some isometric training, increasing your potassium intake. That's obviously in fruit and veg, increasing physical activity, not smoking, reducing sodium. So those would be the kind of lifestyle advice that you could give women at any point. So whether it's pre-pregnancy, whether it's during pregnancy, you can encourage all of these things, or whether it's post-pregnancy. I put this up just because this is the new ESC pathway of how you might measure those people in the middle. There'll definitely be women who have residual hypertension after pregnancy, so greater than 140. But I think there's going to be some women who will sit in this middle category. The new ESC guidance would suggest that actually you should look very carefully as to whether or not they have any other modifiers that might increase their risk. And for some of these women, particularly if you've got renal disease or you've got diabetes, it may be appropriate to start antihypertensive therapy. This is outside of pregnancy, with blood pressures of 120 to 139, which is, I think, a little bit of a paradigm shift in what we've been doing. So why are we worried about it? Well, we're worried about it because if you get gestational hypertension, you may be up to 4 times more likely to develop chronic hypertension. We know you're maybe up to 3 times more likely to have adverse cardiovascular events such as heart attack and stroke, twice as likely to come into hospital with heart failure with preserved ejection fraction. And really interestingly, if you've got preeclampsia or you develop gestational hypertension, you've got a 93% higher risk of developing a dilated cardiomyopathy than the background population. And that's more associated with increased maternal age. So if you've got a mum who gets hypertensive during pregnancy, then there is an increased risk that she may well develop a cardiomyopathic process. And sort of in accordance with all of this, you increase your risk of developing vascular dementia and Alzheimer's disease as well. So hypertension in pregnancy is bad for a woman's long-term cardiovascular outcome. And I think it's really infrequent that this gets asked about when we're thinking about risk factor calculations for more mature women who've developed cardiovascular disease. What are the mechanisms of this? The honest answer is that no one really knows. It could be that you get long-lasting damage to blood vessels from gestational hypertension. It could be that you've got some increased diastolic abnormalities that occur at the time that you get gestational hypertension. Might be oxidative stress or inflammation. It's always inflammation. Or it might just be that it's either bringing forward or uncovering a predisposition to develop these things. So with pregnancy acting as a stress test, revealing a tendency to develop an underlying vascular disease, or it's accelerating the development of pre-existing conditions. So we don't really know why women will get hypertension or will get cardiovascular disease later on in life, but there is incontrovertible evidence that this definitely alters your risk, and that's independent of all of the other factors. So what do you do with it? Well, what do you do with the fact that you know that these women are at higher risk? The honest answer is that you don't know. So obviously, if they've got hypertension, then you should be managing it at least as aggressively as in patients who don't have hypertension, or sorry, without any other risk factors. So, make sure that women are getting the right treatments that they need. It may be that we should be looking at different treatment targets for women, and particularly women in the kind of period between 2 pregnancies. That's a really interesting period of time where we probably do have an opportunity to pick up women who've had one lot of hypertensive disease and modify their risks before their second pregnancy. And obviously, as I said, there are these risk calculators, but they don't really account for younger people and probably underestimate the long-term risk of cardiovascular disease in women. So in conclusion, I hope I've highlighted to you the importance of identifying and treating hypertension before pregnancy, and that you have been able to understand that there are higher risk populations within the populations of women that we look after, where it's going to be worth looking for hypertension either earlier on in pregnancy to ascertain that they had chronic hypertension. We've talked a little bit about how you might manage hypertension during pregnancy, particularly with regards to lifestyle interventions and medical therapy. And I think what I'm suggesting is that we have a call to action for recognising the increased risk that these women have of developing cardiovascular disease later on in life, and indeed the risk that might be conferred to a subsequent pregnancy. Thank you.
Fantastic. Thank you very much, Kate. Yeah, I'm very, very supportive of this. I see patients following preeclampsia at around 6 weeks, and I do feel it's an area that really does need some sort of funding and promotion and resource, because I just worry that I see patients and you counsel patients about the risks of hypertension in later life and to modify their lifestyle, but it's at a time when they've just had a newborn baby. Yep. There isn't anything to sort of signpost or push them into. I don't feel like it'd be great if you could sort of say, well, we're going to provide you now with a personal trainer that's going to look at your diet, it's going to get you exercise, we're going to really work on your salt intake, and it just seems that we know that there is a risk, we counsel about the risk, but then there isn't a sort of very good system then for picking these people up or treating them. And I just wondered whether you think that this is a sort of public health policy, or how can we kind of promote this area that needs to be tackled?
So you're absolutely right, and of course you're right that it's one of the only times of a woman's life, a young woman's life, that she might have medical intervention, and so these things might be popped up. Women get their risk factor modification done later on in life by GPs, so picking up high risk women at that time is really crucial. I think that you're right that some sort of guidance. I sat on a panel a couple of years ago where we were looking at this with the obstetric cardiology societies about developing these kind of risks, and we produced a paper. I'm not certain where it got published, but it did get published, about exactly this, about looking for women who are high risk, giving them targeted advice. The whole system, I mean, this is not just to do with pregnancy, it's the whole system needs to switch its focus towards preventative things. Otherwise, we're just going to spend the next 40 years putting out fires that we could have doused now. So yes, definitely.
Great. There's some other question about I guess about automated machines actually, and you mentioned that sphygmomanometry was the best kind of way to measure blood pressure, but I think increasingly in our unit as well, they've kind of got rid of the manual machines, and we're all using automated blood pressure cuffs. Whether you want to comment on that?
So if anything, they overestimate blood pressure, so you're not going to miss anybody. So I suppose what I'm saying is they might give you higher readings, and yes, there's all of the, what's the phrase, perfection is the enemy of good. So it's probably better that we give everybody automated blood pressure machines and maybe overdiagnose a little bit of hypertension than accept that if you were in a laboratory and you wanted to do it properly, you'd use a sphig. So that's what my opinion would be on that, even though I can appreciate the science behind why it's not effective. There are some that are approved though, so I think that's the important thing. There's only about 6% of monitors have actually gone through any approval. So I think using approved monitors is probably the start of doing it right.
Mm-hmm. Yeah, it's a sort of algorithm, isn't it? I think inside the machine that picks up the vibrations and then calculates blood pressure. It's got to be kind of validated for pregnancy, hasn't it?
Yeah, that's exactly right.
And I guess we're also moving to a system now where we're trying to get women onto home blood pressure monitoring. And I wondered whether you might want to talk about that. And I guess my experience of that is oftentimes you'll see a patient in clinic quite hypertensive, but they're actually just hypertensive because they're in clinic, they couldn't park, been stressed out seeing a doctor, sort of thing. And when you give them a home blood pressure monitor, their blood pressures are often quite a lot better. But I just wondered what you guys are doing with regard to that, and whether that's something you're introducing into your antenatal care pathways.
So yes, we do have home monitoring, and Natalie looks at a lot of the home monitoring, and you're absolutely right that there can be swings in blood pressure. The problem is that the swings in blood pressure when you do other things as well, when you pick up the children and they're late from school, when you are driving and you're stressed. So, and actually we know that white coat hypertension is associated with adverse outcomes. So it might change your treatment targets. It may make you look at your home blood pressure recordings a little bit more carefully, but I would still be quite concerned about a woman who had a blood pressure of 160 who comes to clinic, because it's not just going to be 160 on the day they come to clinic, it must be 160 at other times. So with a pinch of salt, if you'll excuse the pun, given that we're talking about hypertension.
Great, good. And someone asks, do you think we should have a standardized pathway to follow these patients postnatally by their GPs?
Yes.
Like this postnatal sort of follow-up for these patients, yeah.
I mean, ideally, yes.
Yeah. Great.
So someone's asked about side effects from hydralazine. So no, I haven't at the moment. Of course, you can get a lupus-like effect. And yes, I'd usually do switch them outside of pregnancy to something different. And obviously I'm slightly biased because a lot of the women that I look after with hypertension have got concurrent LVSD, and there's really good data to support the use of combined hydralazine. Well, I say good data, it's a long time ago data, but there is some outcome data to support the use of hydralazine and nitrates together. It works a little bit like an ACE inhibitor as a vasodilator. So it's kind of something that I would use in pregnancy, very occasionally outside of pregnancy, but that's really just for people who've got terrible renal function. So yes, usually change it to something else. And with regards to lactation, we use enalapril. I mean, obviously there are small amounts of enalapril that get excreted in breast milk, and you maybe wouldn't use it if you've got very tiny babies, but we do use enalapril postpartum for women.
Yeah, I think that's our practice as well. And just on kind of starting ACE inhibitors postpartum, I suppose, what's your experience of so I think one of the sort of barriers, I think, to using ACE inhibitors is this business of needing to check U's and E's after 2 weeks. And I think that does put quite a lot of people off, because either where do they go for that check? Do they go to their GP? Do they come back to maternity? Who's responsible for kind of following that up? I don't know whether you want to maybe talk about that and maybe what you do in Leeds.
Again, there is a difference between a heart failure patient and someone that's just hypertensive, because heart failure patients, you've got heart failure nurses that will do all of this. So a heart failure nurse would do all of this. As for, I think the other thing, so with regards to hypertension, it doesn't matter what agent you use, actually. There's no very good evidence, unless you're thinking about, the heart failure patient or the women with CKD who clearly ACE inhibitors are better. There's no really good evidence that one is better than the other. So actually, I think the New Yorkshire Healthy Hearts website is going to suggest a vasodilating calcium channel blocker and a thiazide diuretic.
Okay.
But just something. Doesn't have to be an ACE inhibitor. If you're worried about checking their renal function, just give them something. And each one of those will reduce your blood pressure a little bit, and it probably needs to be combination therapy. So everyone thinks if you give 2.5 of Ramipril, it's a quarter as good as 10 of Ramipril, but the dose response curve is pretty flat after you've been on an ACE inhibitor. So you're much better off 2 therapies small doses and then titrating upwards.
Right.
So if you can't be confident that you're going to get your renal function checked, use something else.
Okay. A question from Alison Lee, and I know exactly the patient she's talking about. What would you do with a patient on statin therapy and a single dual antiplatelets that has had a bypass operation for Kawasaki and wishes to get pregnant?
That's like
that's not really hypertension, but
no. So I mean, the first thing is that if she's got Kawasaki disease, statins are predominantly for atherosclerotic coronary disease, so you may not need the statin, would be one thing I would say. I mean, that's probably going to have some long-term benefit. Single dual antiplatelets. So I mean, what have we done with our Kawasaki patients? I think definitely they stay on aspirin. Lots of them can tolerate clopidogrel. Certainly that's what we would use if we were putting a stent in a woman, in a peripartum patient. We'd use aspirin and clopidogrel. So that's if there's a good reason to be on 2 antiplatelets, that's probably what I would do.
Okay, yeah, I think that's our recommendation too. So, I mean, the issue, well, clopidogrel isn't so well studied, is it, in terms of sort of safety in pregnancy? But to my knowledge, I don't think there are any kind of red flags to clopidogrel. So, hasn't been associated, I don't think, with significant increased risk of congenital malformation. And I think normally patients, well, my view is they're normally on clopidogrel for a reason, and if they need dual platelet therapy, then we would normally discontinue it during pregnancy. Yeah. One more question. Although NICE suggests swapping to one antihypertensive medication after delivery to improve compliance in patients on multiple antihypertensives, but these patients start taking a new drug will take longer to adjust to the dose and delay their discharge, which patients do not like and put pressure on service. Well, I think that's getting to the fact that should we try to put someone on just a single treatment for their hypertension after they've delivered? Should we convert them over to something, or should we continue them on multiple medications that they've been taking during pregnancy in order to kind of make their discharge easier? I think that's the question. Sorry, I'm not quite sure.
Yeah, I don't know. I mean, I think it will probably be very patient specific and why they're on which antihypertensives. I mean, we're talking about using antihypertensives that are a bit unusual during pregnancy, but they still work. So you would have to think about what the patient wants. You'd have to think about why you'd chosen that. Why were they on specific antihypertensives before pregnancy? What's their other risk factors? So obviously, if you've got proteinuria renal disease, then you should be on an ACE inhibitor. But you're right that it's a big period of upheaval. And if they are nicely settled on nifedipres and they're tolerating it and their blood pressure is well controlled, I don't necessarily think you should switch it for something different. It's slightly different with things like hydralazine because they do have a higher risk of those slightly nastier complications, and GPs are a little bit less familiar with them. But if you're stable on a little bit of nifedipine and a beta blocker, I'm not sure I would push to change it for somebody immediately postpartum.
Yep. Okay. Thank you very much. Great. Okay. Well, thank you very much, Kate. That was fantastic. So I think it's on to the last presentation now, which is me. So I'm just load up my slides.